Good afternoon. I'm Dr. Maria Rosario Sevilla, and today we will be talking about preoperative risk evaluation and management and its impact on our clinical practice. I have no relevant conflicts of interests to declare. As internists, we've all been asked to clear patients for some reason or another, whether it's a diagnostic or a therapeutic procedure. And this can range from dental surgery to organ transplantation. Preoperative evaluation is part and parcel of our lives, so this is as good a time as any for us to quickly make a review of the principles involved. These are the pre-specified objectives of the session. I will deal with the first half, covering the available risk stratification tools and the needed diagnostic tests for cardiac screening, while my good friend Dr. Jan Anonuevo will talk about the remaining two topics. When it comes to preoperative evaluation, there are two important elements to consider when performing a proper assessment. First, we need to know the surgical procedure to be done. Is it an emergency? What are the chances of having a stormy pre-op and post-op course? The procedure's risk profile by itself may affect the patient's prognosis. The anesthetic technique to be used is also relevant because different anesthetic compounds and their routes of administration may aggravate pre-existing medical conditions. Then we need to evaluate the patient carefully through a good history and physical examination to determine if there are any occult or hidden medical issues that the patient was not aware of. If there are pre-existing problems, then we have to make sure that those are stable and controlled. We can then risk stratify the patient's overall health status, after which we can decide if any further cardiovascular diagnostic tests are needed. Once we have these, then the factors are weighed and also used as a basis for our recommendations, whether to proceed, to postpone, or to totally defer the procedure. Let's start with procedural concerns. As previously mentioned, we need to know the planned anesthetic drug and route of administration. There are three types of anesthesia. First is general anesthesia, which places the patient in a state of unconsciousness with no memory of the pain or any of the procedures that were actually done. The patient is essentially paralyzed, and this is done with the use of inhalational or intravenous agents or a combination of both. Of the 5 inhalational agents that are currently available, I was told that most anesthesiologists in the Philippines use sevoflurane or desflurane. Although the drugs may differ in their effects on blood pressure, heart rate, and systemic vascular resistance, we must remember that all inhalational agents depress myocardial function. Although the myocardial depression is really quite reversible, the negative inotropic effect, however, may wreak havoc on a compromised or failing heart. Also, inhalational GA usually requires laryngoscopy, intubation, and extubation, which can become difficult, especially if your patient has a major pulmonary problem like COPD. Newer techniques such as the use of the LMA or the laryngeal mask airway has allowed some anesthesiologists to avoid the use of an endotracheal tube. But that technique is not totally without complications. Now, GA using intravenous high-dose narcotics, on the other hand, do not cause myocardial depression. With the availability of the very potent fentanyl derivatives with short half-lives like remifentanil and alfentanil, the anesthesiologist now has the luxury of being able to maintain better hemodynamic activity and stability without the need for prolonged ventilation. Now, propofol, on the other hand, is an alternative phenol drug that can be used for both induction and maintenance of general anesthesia. Its major advantage is its rapid clearance from the body with few residual effects on awakening. However, it can cause profound hypertension because of reduced arterial tone with no change in heart rate. Therefore, tight monitoring will be needed to avoid precipitating an ischemic episode due to blood pressure fluctuation. The next type of anesthesia is the regional block, which includes spinal, epidural, and peripheral nerve blocks. Now, spinal or epidural techniques produce sympathetic blockade, which can cause hypotension and bradycardia. However, it may also evoke a reflex sympathetic activation mediated above the level of the blockade, which could lead to undue tachycardia and subsequent myocardial ischemia. The peripheral nerve block, on the other hand, offers the advantage of causing minimal to no hemodynamic effects. The last is monitored anesthesia care, which simply refers to local anesthesia that is administered by the surgeon or the anesthesiologist with or without sedation. One must ensure, however, that the stress response has been adequately blocked, because the ischemia-causing tachycardia associated with inadequate analgesia or anxiety may be worse than the possible hemodynamic effects of a carefully monitored general or regional anesthesia. So to recap, knowing and understanding the types of anesthetic technique is important so that we can anticipate any possible complications that may contribute and provide useful suggestions to attenuate any risks. Now, we go on to the type of procedure. Guidelines suggest that preoperative evaluations may be dispensed with to avoid the undue delay and higher costs if the surgery to be done is relatively low stress or has a low risk for perioperative ischemia or other complications. In fact, they suggest that outpatient procedures that are associated with minimal morbidity and mortality, especially when done under local anesthesia, such as cataract surgery, for example, may not even need a preoperative evaluation unless the patient has unstable angina or overt heart failure. In contrast, open surgery for vascular disease is usually associated with a very high possibility for non-fatal MI and cardiac death. As you can see from this table, highest cardiac risk comes from vascular surgery, while intra-abdominal, thoracic, and orthopedic procedures are associated with 1 to 5% risk, probably because most hip surgeries are performed on the elderly, while intraperitoneal and intrathoracic surgery usually implies significant comorbid conditions in the patient. Now, this is from the 2014 ESC guidelines. I prefer to use this as a guide because it provides more examples of procedures in each category. I just want to point out, though, that based on the newer guidelines, the differentiation between intermediate and high risk is artificial because they will be treated in a similar fashion when we talk about the algorithms later. Now let's go to the meat of the discussion. Nothing can replace a thorough history and physical examination as a basis for good clinical evaluation. Determination of any pre-existing conditions or previously unknown medical condition is critical to establishing the risk profile. Probing for coronary risk factors is a good first step. Don't forget to ask about the presence of diabetes, hypertension, and prior ischemic heart disease, as well as symptoms of heart failure and chronic lung disease. Guide questionnaires such as this one from the University of Michigan may be helpful, and questions on the kidney and liver status, especially if you're seeing a new patient, will be material to the patient's ability to tolerate medications, anesthetic agents, and even contrast dyes that have been known to cause post-op problems such as acute kidney injury. Answers to these questions can help determine clinical cardiovascular instability and the patient's suitability for surgery. In 1989, Latke and his colleagues developed the Duke Activity Status Index. DASI is a 12-item scale in the form of a self-administered questionnaire used to evaluate patients with cardiovascular diseases such as heart failure, CAD, or MI. The clinical use of Duke Activity Status Index includes measuring functional capacity, assessing aspects of quality of life, estimating peak oxygen uptake, evaluating the effect of medical treatments or cardiac rehabilitation, and assisting clinical decisions. The questionnaire assesses daily activities such as household tasks, personal care, and recreation, and provides the metabolic cost of each activity. The DASI score is calculated by adding all the points together, and the higher the score, which ranges from 0 to 58.2, the higher the functional status. Now, you can also predict functional capacity by computing the average metabolic equivalents, or METs, that the patient can perform. Remember, it is recommended that the patient should be able to perform at least 4 METs to be able to undergo a surgical procedure. Up to this point in the process, we have been trying to identify if any of these active conditions exist in the patient. Did the patient have a recent acute coronary syndrome? Is he in class 4 failure? Does he have any life-threatening arrhythmia or severe valvular disease? These are the cardiac conditions which would trigger additional workups or interventions before proceeding with surgery. Multiple studies have attempted to identify clinical risk markers for perioperative cardiovascular morbidity and mortality. Risk can be divided into low or less than 1% and elevated clinical risk. There are several tools available, but in the interest of time, we will only talk about the two most popular ones. These are the American College of Surgeons NSQIP Risk Calculator and the Revised Cardiac Risk Index, or the RCRI. Now, this is the American College of Surgeons National Surgical Quality Improvement Program, or ACS NSQIP Risk Calculator, which incorporates both surgical and clinical risk. This universal calculator is purely online and is accessible to the public. Just enter the data regarding 20 patient characteristics, including the type of surgery, age, sex, and health information, and these are analyzed to predict outcomes for that specific patient. What you are seeing are the data from a patient of mine who will be undergoing major abdominal surgery. And the surgical risk calculator provided the following expected outcomes for my patient, which are thankfully below average. Even the expected length of hospitalization was estimated at 7.5 days. This model was built using data from over 4.3 million operations in the ACS NSQIP database. The model reports the patient's risk of having any of 18 different complications within the first 30 days following surgery, including readmission, UTI, venous thromboembolism, and cardiac complications. However, the ACS NSQIP risk index has a high probability of underestimating cardiac risk because patients did not undergo systematic measurement of perioperative troponin levels in these studies. Without cardiac biomarker screening, more than half of all perioperative MIs go undetected. And this is the likely explanation for the low number of perioperative MIs in the studies that developed this particular risk index. Moreover, the ACS NSQIP risk index has not been externally validated in a study that has systematically monitored troponin measurements after cardiac surgery. On the other hand, the revised cardiac risk index is considered the most widely used index, and it was developed in a study of 4,315 patients aged 50 or older undergoing elective major non-cardiac procedures in a tertiary care teaching hospital. The index includes 6 independent predictors of complications: high-risk type of surgery, history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, preoperative treatment with insulin, and preoperative serum creatinine concentration greater than 2 milligrams per deciliter or greater than 177 micromoles per liter. Cardiac complication rates rise with an increasing number of these risk factors. Patients are stratified into low, intermediate, or high cardiovascular risk based on the number of factors present. The RCRI has become a standard tool and serves to direct the decision to perform cardiovascular testing and implement perioperative management protocols. It has also been validated in vascular surgery cases and helps predict long-term outcome and quality of life. Now, the original paper was published in the late 1990s, so a review of RCRI validation studies over a 15-year period was published in 2017. The review included studies that systematically monitored perioperative troponin measurements and reported event rates for the various RCRI scores. The results showed higher risk estimates for MI, cardiac arrest, and death at 30 days after non-cardiac surgery when compared to the original data. This is attributed to the fact that the original RCRI study monitored CKMB enzyme and excluded emergency surgery cases. whereas the external validation studies monitored troponin levels that are much more sensitive than CKMB, and some studies included emergency surgery patients. These are the numbers now that are widely accepted in terms of risk estimates when using the RCRI. I just want to let you know that there is a new risk index that is being developed by a team from the American University of Beirut. Published in 2019, the AUB HAS2 index derives its name from the 6 identified predictors of risk, namely history of heart disease, heart symptoms of angina or dyspnea, age of 75 or older, anemia with hemoglobin less than 12 milligrams per deciliter, vascular surgery, and emergency surgery. Like the RCRI, patients are assigned a score based on the number of predictors, and the authors showed that the incidence of the primary outcome of death, MI, or stroke at 30 days increased steadily across the increasing scores. This index was validated using the NSQIP database of more than 1 million surgeries, and they claim superiority over RCRI. However, the same criticism of not having systematically monitored perioperative troponin measurements in NSQIP population applies here. As of the latest reports in 2020, validation studies are still ongoing. So, we are done with checking procedural risk and have already risk stratified the patient's status. What should we do next? Several algorithms were developed to help the doctors and the patients decide on whether to go through with the surgery or not. The one on the left was developed by the American College of Cardiology and the American Heart Association, while the algorithm on the right, on your right, is by the European Society of Cardiology, both of which were published in 2014. Their processes are basically the same thing. First question, is the procedure life-saving and cannot be postponed? If so, then surgery has to be done, and we can only make recommendations to help prevent or manage any problematic issues. Second, if there is time to do a medical evaluation, we need to find out if there is any critical or unstable cardiac conditions and manage accordingly. Note that the index procedure's scheduling may be affected by the required therapeutic interventions. For example, dual antiplatelet therapy after revascularization may require several months postponement of the index surgery. If the patient does not have an acute or high-risk cardiovascular condition, then the next question is, how dangerous is the procedure? If it is low risk, then it may be possible to proceed with caution. But if the chances of possible morbidity is higher than 1%, that is intermediate or high risk, then the patient's functional status comes into play. Is he able to do at least 4 METs of activities on a regular basis? Remember, the higher the METs or the Duke Activity Status Index score, the better the event-free survival of the patient. If the answer is yes, then surgery can proceed without further testing. If functional capacity is low, then further cardiac testing may be needed, but only if the test results will affect the decision for surgery. If imaging or intervention will not change the patient's condition or prognosis, then shared decision-making comes into play. Do we bite the bullet and take the risk of surgery, or should we consider other alternatives? Now, this is when the question on necessary diagnostic tests come in. Since we are talking about cardiac screening, we will no longer mention tests that are meant to identify the presence of other medical conditions. The guidelines agree and they recommend that a baseline ECG should be done. If abnormal, it will provide a basis for further investigations to determine the existence of ischemia, heart failure, significant arrhythmia, or severe valvular disease. If normal, then it will serve as the baseline for comparison if a perioperative event is suspected. All other cardiovascular diagnostic tests, echo, stress imaging, and coronary CT angiography, are not recommended to be done as part of a routine investigation. In fact, the 2017 Canadian Cardiovascular Society guideline specifically stated that these cardiac diagnostic tests may just incur higher costs and potential delays, since there is no evidence of an overall absolute net improvement in risk reclassification. Hence, any further diagnostic testing should be done only if it would be indicated, even if no surgery was planned. So if you detect a significant murmur or evidence of heart failure in a new patient, then a 2D echo is very much warranted as part of your preoperative evaluation. However, it is not recommended to be done routinely in all pre-op patients. Finally, I just want to show you the flow diagram from the 2017 Canadian Cardiovascular Society guidelines. They recommend evaluation for patients 45 or older, or younger patients with known significant cardiovascular disease, which includes known history of CAD, cerebrovascular disease, PAD, CHF, severe pulmonary hypertension, or a severe obstructive intracardiac abnormality such as a severe AS, a tight MS, or severe hypertrophic obstructive cardiomyopathy. So how is this guideline different from 2014 ACC and ESC guidelines? If the patient is older than 65, has an RCRI score of 1 or higher, or has a significant cardiovascular condition, then they recommend the determination of NT-proBNP or BNP. This is based on a meta-analysis of 2,179 patients from 18 studies that showed that the preoperative NT-proBNP or BNP measurement was independently associated with the primary outcome of death or non-fatal MI at 30 days after non-cardiac surgery with an odds ratio of 3.4. Importantly, NT-proBNP or BNP measurement done before non-cardiac surgery improved risk prediction. Only 7.6% of patients had an elevated NT-proBNP or BNP measurement before non-cardiac surgery. Death or non-fatal MI within 30 days after surgery occurred in 4.9% of patients with preoperative values below 300 nanograms per liter for NT-proBNP and below 92 milligrams per liter for BNP, versus 21.8% of patients with higher values. Pre-op NT-proBNP measurement was also determined to be much stronger predictor, a much stronger independent risk predictor compared to the 2D echo. The results of the natriuretic peptides will also guide the physician on the type of post-op monitoring that must be done for the patient. In summary, we have reviewed the surgical and the anesthetic risks, which must be considered along with the patient's clinical status. We reviewed risk stratification tools and noted that the updated revised cardiac risk index is still the tool that is recommended by most cardiology societies. Finally, we have seen recommendations on doing a routine baseline ECG and natriuretic peptide testing in specific populations. And on that note, I close my section of the presentation and pass you on to Dr. John Anonuevo.